Good morning everybody. Today I'm going to talk about smoking in periodontium. How does it affect smoking affects periodontium? Smoking, already everybody is aware that smoking causes oral cancer. But first, to cause oral cancer, it has to impact on an oral mucosa and oral cavity, where it does lead to a lot of conditions like precancerous lesions, leukoplakia, erythroplakia, smokeless keratosis, oral cancers, squamous cell carcinoma, tongue, along with floor of the mouth, lip, as well as gingiva alveolar ridge. Okay, so there are a lot other periodontal conditions where smoking has a big impact. It leads to gingival inflammation, periodontal pockets, gingival recession, bone loss, periimplantitis, root caries, halitosis, taste dearrangement, and stained teeth, also for the restorations. Impacted of the smoking. What happens if impact smoking on the periodontium? When it comes to gingivitis, the decreased gingival inflammation and bleeding on probing. When it comes to periodontitis, increased prevalence and severity of periodontal destructions, increased pocket depth attachment loss and bone loss, increased rate of periodontal destruction, increased prevalence of severity of periodontal diseases, increased tooth loss, as well as increased prevalence with increased number of cigarettes smoked per day, decreased prevalence and severity with smoking cessation. As understood, when you reduce the smoking, the amount of disease progression would subside. Periodontitis defined as one of the more sites with clinical attachment loss of 4 mm or greater and pocket depth of 4 mm or greater. It is inflammatory disease of the supporting tissue of the teeth caused by specific microorganisms, resulting in progressive destruction of the periodontal ligament alveolar bone with pocket formation, recession, as well as both. So how do you diagnose or how do you classify smokers? Current smokers, former smokers, and non-smokers. Current smokers are the smokers who've smoked more than 100 or equivalent to 100 cigarettes in their lifetime, whereas former smokers are told as the person who smoked less than 100 or equivalent to 100 in their lifetime, and non-smokers who have not smoked more than 100 in their lifetime, that is non-smokers. And there is a data where smokers 4 times likely to have periodontitis than non-smokers. Former smokers, that is 1.68 times, are likely to have periodontitis than non-smokers, whereas person who smoked more than 9 cigarettes per day are likely to have more periodontitis comparatively to the non-smokers. So if it is greater than 31 cigarettes per day, 6 times likely to have periodontitis. Number of years of tobacco use is very important, because the more the smoking has been impacted, the nicotine is having an impact on the tooth, the oral cavity and the buccal mucosa, everything has been affected. And when it is high risk of tooth loss, as everybody knows, and continuous attachment loss followed by bone loss. Smoking, it is active as well as passive. Active, this person who smokes, when the person next to him who inhales the smoke, the char, is a passive smoker. And then you can talk about what all elements are there in the cigarette which lead to lot of carcinogenic properties. So you have ammonia, nicotine, toluene, hexamine, stearic acid, cadmium, butane, acetic, methane, arsenic, carbon monoxide, methanol. But the basic carbon monoxide and nicotine char is a more carcinogenic effect. The cigar or pipe smoking or reverse smoking also leads to palate, which has been carcinogenic, and you have smokeless tobacco leads to oral leukoplakia and carcinoma. Localized attachment loss and recession is very commonly seen in smokers. So now what exactly happens in the microbiology when the person is a smoker? That microbiology, no effect of rate of plaque. When you try to do maximum scaling and root planing also, the plaque accumulation repeatedly happens. There is no progression in arresting the plaque accumulation. Increased colonization of shallow periodontal pockets with periodontal. When it comes to, there is a shallow pocket also, there is maximum amount of red complex bacteria seen in the shallow pockets. Increased level of periodontal pathogens in deep periodontal pockets. In immunology, we've spoken of microbiology. Now the immunity has also gone down, and how does it affect? The neutrophils and chemotaxis, phagocytosis and oxidative burst is also altered, and increased TNF alpha and PGE2 in the gingival clavicular fluid is increased neutrophil collagenases, which leads to destruction of collagen in the gingiva, leading to attachment loss as well as gingival elasticity is lost. Increased production of PGE2 by monocytes in response to lipopolysaccharides. Physiology. What happens to the physiology? Increased gingival blood vessels with increased inflammation, increased gingival clavicular flow, and the bleeding on the probing will increase inflammation. Decreased subgingival temperature, increased time needed to recover from local anesthesia. So what exactly, as I already mentioned, the microbial load is increased. So what are the bacteria which increase? Are bacterial processes, actinomycetum concomitans and P. gingivalis are all the time present in the pocket, though we repeatedly treat them. Echinella nodotum and Fusobacterium nucleatum and all other pathogens are also increased and more prevalent in smokers comparatively to non-smokers. So as immunology, neutrophil is altered, chemotaxis, phagocytosis and oxidative burst is also increased, altered, whereas PGE2 and TNF alpha are increased in GCF. So physiology has been already discussed. What exactly happens when after the response to the periodontal treatment? Non-surgically, when you treat a smoker, there is no much improvement seen in the gingival inflammation, whereas in bleeding. Decreased clinical response to scaling and root planing, decreased reduction in pocket depth, decreased gain in clinical attachment level, and decreased negative impact on smoking with increased level of plaque control. The surgery, when you do surgery and implants, there is no proper pocket depth reduction when you compare to smoker and a non-smoker. A smoker, the pocket depth reduction is not that evidently seen, whereas non-smokers, the pocket reduction is evidently seen. Increased deterioration of furcation and post. There is no much improvement in furcation treatments as well. Decreased gain in clinical attachment level, decreased bone fill. When you try to put some bone graft in a smoker, there is no much regenerative property, and an increased recession and increased membrane exposure follows by guided tissue regeneration as said. And decreased pocket depth reduction and gain in clinical attachment levels after open flap debridement. As you know, normally only when you do a flap surgery, there is some amount of gingival recession. Whereas in smokers, it's added on and it leads to gingival recession, and a more amount of pocket depth reduction is not much evidently seen. Conflict data of impact of smoking on implant success. And there is smoking cessation should be recommended prior to implant. If the person is a smoker and if he is going for an implant procedure, make sure the patient doesn't smoke or he stops the smoking for a couple of months time, or else the implant might go to a failure. So maintenance, when you see after the surgery, after the treatment also there are no much results, the maintenance also would not give that much. Maintenance therapy may also increase pocket depth during the maintenance, decrease clinical attachment, and there is more chance of recurrent or refractory periodontitis, increased need for retreatment in smokers, increased need for antibiotics in smokers, and increased tooth loss in smokers after surgical therapy. So host defense, as I told you, the smoker will have lot of immunity related issues. Because of that, the host defense is not showing up much proper results, leading to decreased PNF function, decreased ratio of CD4 plus and CD8 plus, decreased salivary IgA and IgG, destruction of extracellular matrix, increased pro-inflammatory cytokines and inflammatory mediators. Example, IL-1, TNF alpha, PGE2, THF alpha, and increased MMPs. These all lead to destruction of periodontium. Compromise in wound healing leads to connective tissue and vascular alterations, lead to decreased oxygen and nutrient supply, decreased collagen synthesis. All the above factors ultimately lead to periodontal disease progression and poor treatment response. So effect of smoking on gingiva
is also altered, nicotine replacement therapy should be always given. In that nicotine replacement therapy, transdermal patches, chewing gums and tablets and lozenges are used. Inhalers and nasal sprays are also one of the nicotine replacement therapy substitutes. Side effects are mainly a lot of GIT problems, dizziness, disturbances, headaches and all. So you can help the patient by giving them proper remedies like hypnosis and acupuncture. Medications like bupropion and varenicline are the drugs available for prescription from a medical practitioner to help the person to stop smoking and want to quit or want to quit and motivate for the dental procedures. So both drugs can be cause drowsiness and side effects. Contraindications must be taken into account before prescribing. Therefore, smoking status should be considered. Diagnosis, prognosis and treatment plan of periodontal patients is very mandatory when it is a smoker.